ovarian tumors classification. They can be surface epithelial stromal tumors, sex cord stromal tumors, germ cell tumors, or metastatic tumors. Four main types. Coming to the surface epithelial stromal tumors, they include serous tumors, mucinous tumors, endometrioid tumors, clear cell tumors, transitional cell tumors, and epithelial stromal tumors. These serous tumors, mucinous tumors, endometrial tumors, clear cell tumors, and transitional cell tumors are further divided into benign, borderline, and malignant tumors. Coming to the epithelial stroma tumors, they include adenosarcomas, mixed Mullerian tumors, malignant mixed Mullerian tumors. Coming to sex cord stromal tumors includes granulosa cell tumors, fibromas, thecomas, serotoli Leydig cell tumors. And coming to the germ cell tumors, teratomas, dysgerminomas, yolk sac tumors. Neoplasm, ovarian neoplasms. Type 1 progresses from benign tumors through borderline tumors and may progress to a low-grade carcinoma, whereas type 2 tumors arise from inclusional cysts or fallopian tube epitheliums via intraepithelial precursors, serous tubal intraepithelial carcinoma, which are often not identified, and these tumors are very high-grade serous type. Cross picture of serous cyst adenoma of ovary showing papillary formations. Serous cyst adenoma of ovary with cystic areas and solid areas. Serous cyst adenoma of ovary with papillary projections on gross, and microscopically papillary projections are seen. Momo bodies and the neoplastic cells in a papillary serous cyst adenocarcinoma. Ovarian papillary serous cyst adenoma and also papillary serous cyst adenocarcinoma. Low-grade carcinomas are well-differentiated carcinomas, and the high-grade are moderately to poorly differentiated carcinomas. Differences. These carcinomas low-grade arise from serous borderline tumors, whereas the high-grade arise in the fallopian tube fimbria or from serous inclusion cysts within the ovary. And molecular changes include KRAS or BRAF oncogene signal transduction pathways present in low-grade carcinomas 50 to 60%. It is absent in high-grade. TP53 mutations are rare in low-grade carcinomas, whereas it is almost all common in high-grade carcinomas. BRCA1 and BRCA2 mutations are not seen in low-grade carcinomas, whereas it is seen in 50% of the cases in high-grade carcinomas. Cross and microscopic picture of mucinous cyst adenoma of ovary. Cyst adenoma of ovary. In the exams, you have to draw the diagrams. Mucinous cyst adenoma of ovary showing the cyst lined by tall columnar cells and basally situated nuclei. BRENNER's tumors. These are the spectrum of epithelial neoplasm composed of urothelial type of epithelium. Types. Most commonest is benign BRENNER tumors. As I said, every tumor is subdivided into benign, borderline, or malignant. It can be benign, borderline, or malignant. So, most commonest is benign BRENNER tumor, usually unilateral, seen in 40 to 80 years of age group, with gross features showing solid masses of varying size with a smooth external surface, and cut section is very firm, yellowish or white, containing small cysts. Microscopically, these BRENNER tumors show well demarcated nests of cytologically bland urothelial type of epithelium enmeshed in prominent fibromatous stroma with frequent luteinization, and the cells show nests of central microcysts which may contain the eosinophilic material, and there will be longitudinal nuclear grooves exhibiting the characteristic coffee bean nuclei. Dystrophic calcification may be seen sometimes. Clinical picture. These BRENNER tumors are frequently asymptomatic and are associated with mucinous cyst adenoma. Tumor showing nests of transitional type of epithelial cells. Seminoma. This is a malignant germline tumor of ovary, and it is a counterpart of testicular seminoma. Mostly it is unilateral, and it is most commonly seen in 20 to 30 years of age group, and the predisposing condition includes gonadal dysgenesis. Morphologically, a dysgerminoma. On gross examination, Cut section shows solid yellow to white or grey to pink and soft and fleshy areas. Microscopically, the tumor cells are in sheets or cords which are separated by a scant fibrous stroma and they are infiltrated with lymphocytes. The tumor cells are large with clear cytoplasm and well defined cell boundaries and centrally placed regular nuclei. This germinoma is seen in most associations with benign cystic teratomas. The grass, you can observe the soft yellow-white lobulated tumor occupying the entire ovary. And the microscopical picture shows monotonous type of cells, tumor cells which are separated by fibrostroma, and the fibrostroma is infiltrated by mature lymphocytes. Cut section of stromal ovary showing numerous colloid filled cysts, and on microscopy also you can see the colloid filled thyroid follicles of varying size. Benign teratoma, also called as dermoid cyst. It is the most commonest germ cell tumor of the ovary and it is mostly unilateral and is seen in young women. Origin of dermoid cyst is considered as ovum after the first meiotic division in majority of the cases. On gross examination, you can see in most of the cases unilocular cystic masses with hair and sebaceous material. And the cyst wall is thin, lined by grey-white wrinkled epidermis with protruding hair shafts. Sometimes tooth structures and areas of calcifications may be found within the wall. There is a pultaceous sebaceous material in the ovary, and on microscopy you can observe stratified squamous epithelium and sebaceous glands and respiratory type of epithelium and areas of fat cells and cartilage also. Dermoid cyst of ovary with cartilage, mucous glands, epithelium, hair, etc. Cystic wall is lined with stratified squamous epithelium with the underlying sebaceous glands and hair shafts, cartilage, bone, thyroid and neural tissue may be found. Complications: rarely malignant transformation to squamous cell carcinoma can occur, and paraneoplastic syndromes include inflammatory limbic encephalitis. And most of the times this dermoid cyst is associated with mucinous cystadenoma and dysgerminomas. The sites of teratoma can be seen in testes, ovary, mediastinum, retroperitoneum, head and neck regions. Yolk sac tumor with germ cells and central blood vessels. Sex cord stromal tumors, estrogen producing tumors, granulosa cell tumors, thecomas. Clinically, there will be precocious pseudopuberty in pediatric patients and postmenopausal bleeding in postmenopausal patients. That is two extremes. And in androgen producing tumors includes serotoli Leydig cell tumors and Leydig cell tumors, showing clinical picture of virilization. These are sex-cord stromal tumors are also called as functioning ovarian tumors. Pure fibroma of ovary showing solid spherical grey-white appearance on cut section. Granulosa cell tumor of the ovary with Kohl-Exner bodies and coffee bean nuclei, characteristic features of granulosa cell tumor of ovary diagnosis. And on cross examination you can observe solid tumor replacing the entire ovary.